Welcome back to Diabetic Foot Files. I'm Dr. G. Today we're going to talk about a underestimated, I would say undervalued, but people don't really talk that much about it, is the spirometer, the extensive spirometer. So a spirometer, it seems like a simple test, but after surgery, it becomes something more serious. So most people see it as this little plastic toy that they hand you after surgery, the one with the floating piston or the little ball inside. And patients often think this is optional. Sometimes they think it's annoying, or sometimes they never touch it. It honestly, it becomes a predictor of whether you recover smoothly, actually, or whether complications could start stacking up silently in the background. Because surgery doesn't just end with the incision being closed, right? Surgery is actually a timeline. That's why we have a post-op recovery period. And the body responds in predictable phases. So clinicians understand post-op complications. We have like wind, water. These are post-op figures, right? Wind, water, wound, water, wonder drugs, right? And walk. And so this helps us understand early surgical complications before they become emergencies. So, who invented the spirometer? Somebody who had the similar last name as me. So, the spirometer was invented in 1846 by English surgeon named John Hutchinson. He created the first water-based spirometer, 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 however anybody pronounce it. I could say spirometer. Let me just say, I just want to say spirometer, and to measure the lung function and introduce the term vital capacity. And the equation of vital capacity is VC, so that stands for vital capacity. So VC equals TV. TV is tidal volume, and tidal volume is the normal amount of air moved in and out during regular breathing, plus IRV. IRV is the inspiratory reserve volume. So this is the extra amount of air you inhale after a normal breath in, and plus ERV, plus ERV, which is your expiratory expiratory reserve volume. So that's the extra amount of air you can forcefully exhale after a normal breath. And together, these volumes represent your lung functional breathing reserve and overall pulmonary capacity. So BC equals TV, tidal volume, plus IRV, your inspiratory reserve volume, plus ERV, your expiratory reserve volume. And so this surgeon, Hutchinson, discovered something pretty much revolutionary. He discovered that people with lower lung capacity often had shorter life expectancy and more severe diseases. So this is one of the earliest examples of physiology being used to predict outcomes. And over 170 years later, we're still using the same principles today. So why does a spirometer or spirometry matter after surgery? So after surgery, your body is under stress. The anesthesia slows your breathing. Pain limits your deep inspiration. Immobility reduces your lung expansion. Mucus clearance decreased, as well as your oxygen demand increases during healing. So what's happening? Your lungs often become the first system to quietly fail under stress. So that's where the spirometry comes into play. So after surgery, the biggest early danger is not the incision, right? It's what's happening to your lungs if your lungs stop fully expanding. So there's something, one of the biggest post-op problems is atelectasis, okay? I'm just gonna spell it for you if you confused about how I'm pronouncing atelectasis. ATELECTASIS. So one of the most common early complications after surgery is atelectasis. So what is atelectasis? It is the collapse of small airways. So it happens because patients breathe shallowly, like breathe shallow during pain, like due to pain. Anesthesia also suppresses your respiratory drive. Mucus plugs kind of sometimes accumulate in your small airways, as well as your lung base stops expanding. So this reduces your oxygen chain exchange overall. And the oxygen, as we know, oxygen is a big healing currency for us. Oxygen is everything. This should be oxygen B plus. So wound healing, immune function, infection control, tissue repair. So when the lung expansion drops, your healing efficiency also drops. And that's why a spirometer, right, is often used in post-op because it's also encourage deep breathing. It prevents collapse, atelectasis. It helps maintain oxygenation. So oxygenation, okay? So it's not just a breathing exercise tool, it's a complication prevention device. Why does incentive spirometry help? Incentive spirometry forces deep inhalation. So that means it re-expands the alveoli, it improves ventilation, it mobilizes mucus, it increases oxygenation, as well as it reduces post-operative pulmonary complications. So it's essentially lung rehab immediately after surgery. So when do these post-op issues usually happen? So timing matters. So 0 to 24 hours post-op, anesthesia effects still are present. Highest risk of hypoventilation as well as early atelectasis can begin. 24 to 72 hours post-op, pain usually peaks, shallow breathing increases, mucus retention begins, as well as atelectasis becomes more clinically visible. 3 to 5 days post-op, pneumonia risk increases if the lungs weren't expanding properly, and infection risk also begins increasing. So the lungs don't usually fail immediately from infection first. They fail from mechanics like pain, immobility, and shallow breathing. So I'm pretty sure people heard wind, wound, water, walk, wonder drug, right? And this is a classic way clinicians remember these early post-operative complications. So when I don't think I'm not gonna go through walk, even though that's a DVT. We'll see what I go through. But when respiratory complications, so when happens early, so that includes atelectasis, pneumonia, ventilation, pulmonary embolism, that usually happens with the walk, right? Later overlaps, but that's a risk, okay? With wind as well. Oxygen desaturation and why wind, that's because it represents the airflow and the breathing. And after surgery, airflow is often the first system that's disrupted. So why does wind clinically matter for all of us? Like I said, shallow breathing, your oxygen drops, your wound healing slows down, the infection risk increases, and fatigue increases. So this is where a spirometer becomes critical. So it actively forces deep inhalation, lung expansion, alveolar recruitment, and so we're there. Now, wound. That's our surgical site complication. This often typically shows up slightly later, and it includes infection, wound dehiscence, like a wound dehiscence is a wound opening, hematoma, seroma, poor healing. So this phase usually appears around day 3 to even day 10 even. And why is that? Because inflammation is peaking, tissue repair is beginning, and if oxygen is low, let's say aka from some wind problems, right? Wound healing suffers. And if your glucose is high, right? Your healing slows further. And if your circulation is poor, your tissue breakdown is increased. So wind and wound are tightly connected. Now, water, urinary complications. Water often refers to urinary retention, fluid overload, dehydration, electrolyte imbalance, kidney strain. This often happens between 24 to 72 hours post-op. And why is that? Because anesthesia also affects your bladder function. IV fluids shift your body balance. Immobility disrupts your normal elimination. And stress hormones alter your kidney regulations. And also in our diabetic patients, this becomes even more important because kidneys may have already been compromised, their fluid shifts are already affected from wound even perfusion. And no, the fluid shifts actually affect the wound perfusion, and then dehydration worsens the healing if they're dehydrated, unfortunately. So how do we connect this all back? And we'll go into a walk and wonder drugs in another episode. But how do we connect all this back to the spirometry? Spirometry is not just about the lungs. It connects the whole entire wind phase of recovery. So the wind controls everything downstream. So oxygen delivery helps with our wound healing. Oxygen delivery helps with our immune function. Oxygen delivery helps with our infection resistance. And if wind fails, wound complications increase. Water balance becomes harder to regulate because your kidneys need oxygen too. So everything is connected through your oxygen delivery. So now let's bring it home to our wound care. So in our diabetic foot patients post-op, let's say you took it for the OR for debridement or amputation, grafting, drainage procedures like the IND, same rules apply. So if the wind is compromised, such as like atelectasis or something like that, right? The lower limb oxygenation drops, your wound edges become hypoxic, infection increases, graft failure increases. So if a spirometry is poor, let's say if the spirometry is poor, the patient cannot expand their lungs effectively, oxygen saturation drops, microcirculation suffers, and healing slows down dramatically. So what looks like a foot problem is actually a systemic recovery problem. So let's do our clinical timeline of post-op risk. I think we already went through that. We said immediate is 0 to 24 hours. Anesthesia effects, wind suppression begins, and early oxygen risk. 1 to 3 days, you have your wind complications peaking. Water imbalance does show up. Pain limits mobility. And then, like I said, with the wound complications, they usually emerge around 3 to 7 days. Infection risk rises, and healing response becomes visible. And then, like I said, I will go into the walk and the wonder drugs in another episode. It's just trying to keep this episode nice and short and focus on spirometry. But the spirometry may look like this simple tube toy, right? That's on the side of your bed and they ask you to use it and breathe, right? But in reality, it is something much bigger. There is a purpose behind it. So it represents how well your body can protect itself against or after surgical stress. Okay. So when you're thinking about that with your post-op recovery isn't just about closing a wound. It's about whether your body can breathe, balance, and heal through every phase of stress when it comes to recovering post-operatively. And I hope everybody enjoyed this episode of Diabetic Profiles. I know I didn't go even that much in of what you need to do if these complications arise. That'll be in another episode to expand more. But this is Diabetic Profiles. I'm Dr. G, and take care of your feet because they take care of you.